I'll be presenting our first case today for Chiefs rounds. So we'll go ahead and jump right in. I have no relevant financial disclosures. Dr. Canesa, can you tell me what you're seeing here on this external photograph?
Yeah, this is an external photograph. Looks like the lids and lashes, the lashes are a little bit short. They may have been cut, or there may be some matarosis. Attention's drawn to the limbus, where inferiorly there's appears to be a melt and uveal exposure perforation. The anterior chamber appears relatively quiet. I don't see a hypopion, but there's iris prolapse there.
We'll get you some better images here in a second.
Yeah, so definitely some infiltrate around that perforation there, and a pretty sizable uveal prolapse. Some injection around there as well. Same slice there. Doesn't look like there's there. It's hard to tell if there's epithelium covering that in this photo, but doesn't look like it.
Can I make a comment about the lashes?
Yes.
This could be one other condition, trichotillomania, where people pick at their lashes and at their scalp. It's a psychiatric disease, and the lashes look like this. They're broken.
Are there any associations with trichotillomania?
Well, you have broken lashes, loss of hair in the scalp. I'm not sure of corneal associations, but that's where I would suspect there might be.
The same kind of thing here. It looks like there's some thinning that extends beyond that infiltrate as well, some stromal loss within that slip beam.
Okay, thank you so much. And then can you tell me what you're seeing in this, the contralateral in that left eye?
Yeah, so similar appearance of the lids and lashes. There appears to be kind of a diffuse infiltrate, hard to see the chamber, although it appears deep. Some injection as well here. Again, can't tell if there's an epithelial defect, but from the light reflex, it looks like there's a diffusely irregular epithelium.
Patrick, can you go back?
Yeah.
Speaking of the light reflex, is there a contact lens in the eye?
I think you may be able to get a little bit better view. Dr. Magpara, can you tell me what you're seeing here?
Yeah, again, diffusely injected conjunctiva. There looks like there's something here. Almost looks like a contact lens. And then underneath the contact lens on the cornea, you've got this diffuse patchy infiltrate. Hard to gauge right now whether the epi is intact or not. Yeah, that's a contact lens.
So ultimately, there were noted to be 3 contact lenses on this eye. You can see the outline, one here, another right along here, and a third here.
Therapeutically, would you ever put 3 contact lenses on the eye?
No.
No.
You can see the contacts quite well here.
Are these the size of a bandage lens, or you can't tell?
This looks like a regular soft contact lens that someone would wear for refractive error. This happens more frequently than you think. Patients think that they took their contact lens out, so they put another one in. And I think Chris, years ago, pulled out 13 contact lenses out of a patient. Yeah, so.
In the fornix or on the cornea?
A little bit of both.
He was on the news for that one, I think.
Yeah.
This gives you a little better view at the cornea. We do not have photos of the cornea after the contact lenses were removed. The patient was noted to have a large central epithelial defect and did not tolerate the exam well at that point. We get a few more views here of what we can see of that
And again,
cornea.
you've got those missing or broken lashes here as well. So as Carol was saying, this could be trichotillomania, it could be chronic eye rubbing as well.
So to give you guys just a little bit of the history, our patient is a 44-year-old woman with a past medical history of alopecia, as well as a past ocular history of contact lens wear, who presents with 2 weeks, she stated, of worsening pain, redness, photophobia, tearing, and blurry vision. She says she stopped wearing her contacts 2 weeks ago when the irritation started. As far as her past ocular history, notable only for soft contact lens use, past medical history, alopecia, her past surgical history, she'd had a nasal septal repair and wisdom tooth extraction. She was on no medications. She endorsed social drinking, rare smoking of cigarettes. She denied any drug use. Her mother had rheumatoid arthritis, and her sister has lupus, so a strong autoimmune family history. And her review of symptoms other than lash and hair loss was non-contributory. On exam, her right eye with that kind of large area of uveal prolapse was her better seeing eye at count fingers. She was hand motion in the left eye. The pupil on the right was peaked inferotemporally. Pupil on the left was poorly visualized. Pressures were deferred at that time, given concern for severe corneal thinning and perforated right cornea. She had full fields to confrontation in the right eye, was unable to do confrontational fields in the left, although the EOMs were noted to be full, and the lids were notable for these very short, stubby lashes and lash loss, as we've discussed. And so we've talked about the lids. The conjunctiva sclera had this 4+ perilumbal injection. As Dr. Canesa described for us, we see this circumferential and about 3.5 millimeters radial perilumbal perforated ulcer with iris plugging, significant adjacent thinning for a couple clock hours on each side. It was noted to be Seidel negative, and this area of iris had apparently epithelialized. And the left cornea had the 3 contacts removed with the jewelers. She had a geographic central epithelial defect and kind of these multifocal infiltrates with moderate thinning. This left eye was Seidel negative, had diffuse 2+ brawny edema and 360 limbal NV. The right eye had 2 to 3+ cell, but was deep other than the area where there was the iris prolapse. And the left AC was poorly visualized, but had grossly, mild cell, no hypopion. And the DFE in the right eye was a hazy view, but was normal, and the B scan was clear in both eyes.
What was her pressure?
The pressure was not taken.
So when you have a perforated eye, you don't do applanation.
Don't do applanation. You can do tonopen very carefully. You can do a very gentle tactile pressure as well, but I wouldn't applanate.
Okay.
I think in this case, given the obvious uveal prolapse, and I think it was a challenging exam with how uncomfortable the patient was, particularly after that contact, those several contacts removed from the left eye, I think that kind of guided the decision that the applanation pressure might not make a huge difference in management. So just thinking back to the prolapse in the right eye and those 3 contacts on the left eye, the decision was made in the emergency room to remove the contacts, despite a gross view of some significant thinning in that left eye. Would you have left the contacts in, Dr. Megpar, or do you want to take them out and really get a better look at that cornea?
No, I would definitely take them out. And I think when you have such a complicated picture here, just taking your approach, you have to kind of systematically think about things, right? So, the question one is this infected or not, right? And if you think it's infected, you got to get the contact lens out, get a better look, and then you'll probably. Are you asking me what I'm going to do next now?
We'll get there.
Okay. But yeah, so for this eye, you've got multiple contact lenses in the eye. I think you got to take the lens out and get a better look and probably culture it.
So that is what was done. So what's your differential at this point, and is the differential the same for each eye?
Right, so exactly. So let's go back to your picture of the left eye. So
Left
when you
eye.
have, the right eye. Okay, so with the exception of this, the rest of the cornea actually looks pretty clear, right? So in general, if you're gonna have an infection that's leading to a perforation this severe, I'd expect, honestly, the cornea look a lot worse. Now, there is some whitening here. You can call that an infiltrate. That could just be kind of crummy epithelium as well.
And I think a lot of that was noted to be mucoid,
Yeah.
like discharge, that was not wiped away given the iris was prolapsed.
Yeah, so I mean, the question is, obviously infection has to be on your differential, but is this more than just an infection? So, is there some sort of, autoimmune melt going on? Is the patient neurotrophic? I mean, these are things that I would think about for this eye. For the left eye, the patient had 3 contact lenses in the eye, and that does that does look like an infiltrate. That does look infectious. So, I think infection would be, top on my differential here. So, sometimes the same thing may not be happening in both eyes.
Yeah, so our differential for the right eye, with this clean-based thinning and ultimately perforation, inflammatory, PUK, neurotrophic, potentially traumatic. The history here is a little bit unclear, and include in that some sort of chemical or toxic exposure, and then other infectious etiologies or other inflammatory etiologies a little bit lower on the list. For the left eye with these 3 contacts in for at least 2 weeks, but potentially much longer, infectious etiologies much higher on the list, and kind of viral, neurotrophic, inflammatory a little bit further down on the list. So, Dr. McPar, you addressed this a little bit already, but Occam's razor, so is there one unifying diagnosis for these 2 eyes, or Hickham's dictum? Are people allowed to have 2 things at the same time? So as far as next steps, any specific questions you or Dr. Canesa want in the history that's going to kind of guide treatment, labs, meds, any consultants?
Yeah, I'd get a pretty thorough review of systems to figure out if there is some sort of, autoimmune thing going on. Same thing with labs. I'd get all your kind of autoimmune labs. I don't know, JP's here, if he thinks this looks like some sort of inflammatory melt. The other thing is, to kind of try to put everything together, someone that has had 3 contact lenses in this can happen to anybody, but I wouldn't expect you to have 3 contact lenses in your eye on a day-to-day basis. So, is there something else going on with the lash loss? I've seen this a fair number of times now, but someone with methamphetamine abuse or crack cocaine abuse, you can get a lot of weird things that happen to the cornea, and one of them is a perforation. So that's something. And as far as medications go, labs I would culture, and I would start antibiotics, fortifieds in both eyes. Surgery. I was just going to address surgery. The chamber is deep on the right, but that is not a long-term viable way to leave that eye. So eventually something's going to have to be done about that right eye, probably a patch graft.
Yeah.
Had she been seen in any emergency rooms?
She has.
The other thing you want to ask about is, and sometimes this is hard, the patient will deny it, but you have to ask about topical anesthetic use. They'll steal a bottle of proparacaine because they go into the ER and they say, wow, that I feel so much better. And particularly in that left eye, the non-healing epithelial defect, along with that possibly stromal infiltrate, could certainly be consistent with a long-term anesthetic abuse pattern.
Absolutely. So this patient, on further history, not on the first history taken in the middle of the night, where the patient was very uncomfortable, she endured several months of bilateral ocular irritation, having gone to multiple emergency departments several times in the last 2 months for similar episodes, but not to the same severity, so more mild episodes. She said she'd been relatively comfortable with fair vision. Exactly what that means between episodes is unclear. And she endorses only to the rheumatology medical student that she's an active user of crystal meth and endorses smoking the substance. Continues to deny this to any of the physicians on the rheumatology or ophthalmology team. And rheumatology was consulted. An extensive rheumatologic review of systems was completely negative aside from hair loss. As far as labs, the lab workup guided by our team with input from the rheumatology team was extensive. Rheumatoid factor, CCP, ESR, CRP, this entire list, including things like syphilis, Lyme, hepatitis, HIV, quantiferon gold, was all negative. Urine drug screen was notable for amphetamines and opiates. And only the left eye was cultured initially due to concerns for the perforation in the right eye and safety of culturing that eye, but it showed a polymicrobial infection with Corynebacterium and H. flu. Patient also underwent chest x-ray and MRI of the brain as part of her rheumatologic workup, looking for any other abnormalities, and those were both noted to be within normal limits.
Why the MRI?
I think the patient was very uncomfortable and was acting somewhat unusually. There was no MRA of the head or anything looking for cerebral vasculitis, but I think the rheumatology team was just trying to get to the bottom of maybe why the patient was so uncomfortable and maybe seemed a little bit off of what was assumed to be her baseline.
The opioid and methamphetamine use wasn't a tip-off?
So these were done prior to the UDS resulting.
Nasal, or she didn't have a past history of cocaine, also with the nasal thing.
Not that she reported.
Yeah, but that would be a good reason for the MRI because it would show the loss of the nasal septal defect. And also sometimes they'll use their conjunctiva for deposition of the cocaine.
She didn't report any history of that in this case, but certainly concerning. The rest of her hospital course, as we discussed, rheumatology was consulted, given concern for PUK and a mixed picture with possible other substance abuse. The patient was recommended that once the syphilis came back negative, that we start pulse dose IV steroids. For the perforated cornea in the right eye, the patient underwent a patch graft on hospital day 2, delayed due to patient factors. And she was treated as a ruptured globe with IV antibiotics. And both eyes were treated with topicals, the left eye more aggressively than the right. As far as her clinical course, she was discharged after 72 hours of IV antibiotics and IV solumedrol. She was discharged on oral prednisone in consultation with rheumatology and was due for close follow-up with rheumatology. The right eye had been healing well for several days after the patch graft, was on kind of the standard post-op meds, and the left eye without active infiltrates was treated with Vigamox 6 times a day and ointment at night. So we don't have pictures from her one kind of 5-day post-op, 8 days after initial presentation, but we have these excellent slit lamp drawings. The patient was 2,600 in the right eye, 2,500 in the left. Pressures were normal OU. That right eye, you get a good sense for just the size of the patch graft. Looks like it's about from 5 o'clock to 10 o'clock in that right eye, sparing the visual axis. And it was well-positioned sidal negative graft with sutures intact at that time. The left eye, you can see these areas with, less than 35%, so definitely less than 50% tissue loss here in these kind of multifocal, inactive appearing infiltrates without significant neovascularization.
Whoever the resident was that drew this picture is in the 99th percentile of quality of images that we get in the cornea clinic. So kudos to whoever this was.
It looks like it was updated by one of our more particular cornea attendings. Multiple handwriting.
In the right eye, you had mentioned that the prolapsed iris was epithelialized. Do you do an epitheliectomy at the time of reposition of the iris? Do you excise that iris? What is your concern about epithelial downgrowth after the graft?
Dr. McParr.
Yeah, I can take this one. JP, I would definitely not excise the iris, if possible. If it looks like viable iris and it's not necrotic or infected looking, definitely leave the iris there. Try to reposition it back in. I do remove the epithelium though, so you want to try to get all of that off. So oftentimes it'll just come off in a sheet because of the exact concern that you have is epithelial implantation into the eye. And then oftentimes what you'll do is adjacent to that area of thinning or area of perforation, there was kind of thin, not so great looking stroma there as well. So you'll debulk that. We're not necessarily creating an opening in the cornea that big. So it's not like a penetrating keratoplasty where you're trephinating and removing the tissue. You're just kind of debulking, getting rid of the epithelium, and then putting on a patch graft and fitting it in that shape.
So that patch graft is sitting on top of her recipient cornea.
There is still some host cornea there.
Okay, because that's kind of an odd shape for a tectonic graft.
Yeah, it is one of those things that, you'll debulk because you want the donor to fit in, but you don't want to create an even bigger hole and make a much more unstable situation in surgery. And a lot of times it's putting the donor on, kind of eyeballing it, and then like trimming it a little bit. So it's not an exact science. There's a little bit of an art to it to try to get it to fit.
And do we anticipate this will eventually opacify?
Yes. Fortunately, it's in the peripheral cornea, so she could probably still maintain pretty good vision, but a lot of times if we're doing these, we'll counsel the patient that you may need a second optical penetrating keratoplasty in the future.
Was psychiatry involved? Because, you know, if she went and started smoking the crystal meth again, would that affect the, you know, what you're seeing here and recurrence of same?
It would almost certainly affect it. Social work and the family were involved heavily. I do not believe psychiatry was formally consulted.
Actually, thinking about it, psychiatry may have been called because she was refusing surgery for a little bit to determine if she was sound of mind to do that. And then she eventually came around and decided to go through with it, but I do believe they were consulted for that matter. But, I mean, you know, these patients are, so I was going to ask, you know, when did she came back at post-op month 1?
This is our last exam. I think frequently in some of these cases that are associated with substance use and damage to the cornea, follow-up is challenging. So this is the last follow-up we have. She was noted to have neovascularization and some significant haze of the graph, as you discussed, she'd be at risk for, but the left eye was grossly stable.
Yeah, I mean, it's a really unfortunate thing that I'm seeing more and more over the last few years. These corneal perforations that don't really look infectious, and with this history of methamphetamine abuse, and it's a really big challenge to take care of these patients, as you'd expect. I mean, one, just trying to get them into the OR to agree to have surgery, and then, you know, I still can think of, you know, 2 or 3 individuals that had a perf. They would keep showing up to the OR every day and then just leaving without, you know, we can't tie them down and force them to have surgery. I haven't seen some of these folks back. So, and then, yeah, ongoing follow-up, it is a real challenge, you know, I think globally, to take care of these patients.
Yeah, absolutely. So just to discuss a little bit about PUK, which is what maybe this right eye looked more like in an isolated setting. It's most often associated with rheumatoid arthritis, so can occur in association with other inflammatory diseases, and rarely in the absence of systemic connective tissue disease. Patients typically present with peripheral stromal infiltrates or corneal melting. Rarely central ulceration and stromal keratitis can be related to PUK, and the peripheral ulceration, as we saw in this case, may occur without significant surrounding inflammation. Typically, it extends first circumferentially and then may extend centrally. Mainstays of treatment are lubrication, topical cyclosporin, and systemic rather than topical NSAID steroids, or ultimately, in severe cases, immunosuppressive therapy. And typically, topical steroids are avoided in cases of corneal ulceration. But this case may not fit a clear pattern of PUK, and this patient was an active smoker of methamphetamines or crystal meth. It's formulated from a combination of over-the-counter ingredients, including ephedrine and pseudoephedrine in different over-the-counter medications, as well as chemicals, including acetone, ammonia, hydrochloric acid, toluene, phosphorus, freon, alcohol, benzene, gasoline, and lithium. It may be diluted with other substances, including lidocaine or procaine. So whether or not this patient was using topical anesthetic drops, there may have been kind of a similar effect from diluents in the methamphetamine that was frequently going into her eyes. So she could have had a similar effect without actually having used those eye drops. Crystals of the drug are extracted that are then heated, and the vapors are smoked and inhaled. Should probably go without saying that there's no quality control in this process, and there's variable purity and residual amounts of these added chemicals. And Dr. Magpara, as he mentioned, he's seeing more and more of these cases. According to the NIH, this data is a few years old, but nearly 1 million people aged 12 or older hadn't just used methamphetamine, but had a methamphetamine use disorder in 2017, and this number had been rising in the several years leading up to this. So we have a little experience with corneal ulcers associated with aerosolized crack cocaine use. It may be a similar mechanism. Unfortunately, none of our Wills docs on this paper were able to make it this morning, but this is our patient population, 4 patients in Philadelphia, likely all of whom came through the ER. They all had large infiltrates with evidence of keratolysis or corneal melting. Cultures in all patients revealed polymicrobial infections with atypical organisms, similar to our patient's left eye. And this paper discusses 4 possible mechanisms of damage. One is the direct toxic effect, damaging epithelial plasma membrane and microvilli, also decreased corneal sensation and nerve damage as a result from, directly from methamphetamine or the crack cocaine affecting the cornea and causing neurotrophic damage, as well as material used to cut or dilute the drugs that could damage corneal nerves, such as lidocaine or procaine, and as well as the alkaline nature of crack cocaine that may cause low-grade chemical burns to the cornea and chronic ischemic damage. And they suggest there may be benefits to frequent ointment, doxycycline, low threshold for tarsorrhaphy, and all 4 of these patients were admitted to the hospital for topical therapy, although they weren't perforated at the time of presentation. So keratitis in methamphetamine abusers was first described in cornea about 25 years ago as methamphetamine use became more common in California. These cases, 4 cases, describe rapidly progressive peripheral corneal thinning in methamphetamine smokers with polymicrobial ulcers. These ulcers healed very poorly despite topical therapy and all perforated despite close monitoring and aggressive treatment. Notably, these patients were not admitted for this treatment, and they theorized that the damage is a combination of neurotrophic keratopathy and chemical injury. Interesting point from this study is that they mentioned that methamphetamine is concentrated in saliva and therefore likely tears at 10 times the level of the plasma, regardless of the route of administration. So it's not just building up there from smoke in the eye. Even if it's injected through IV, it's actively secreted into the saliva, and we think likely the tears, which may be responsible for some of this really significant corneal toxicity, and diluting substances as well, such as bicarb, lidocaine, procaine, once again, may also damage corneal nerves and epithelium. They have many other theories on causes. And one of our own recent cornea fellows, Buck Bennett, was a corresponding author on this case report submitted to Cornea just this year. Certainly far from a randomized controlled clinical trial, but it's tough to do with these cases because the history is often unclear and follow-up is challenging. But they report 2 cases of culture-negative corneal inflammation and thinning temporally associated with smoking crystal meth. The first case shows bilateral peripheral thinning with dysmetaseals and a perforation. The photographs are very similar to what we see in our own case, and decreased corneal sensation in chronic crystal meth smoker. The second case is a patient with unilateral multifocal sterile infiltrates with onset within 1 week of smoking crystal meth, looking much more like our patient's left eye. Both patients had extensive negative rheumatologic and infectious workup, negative corneal cultures, and they kind of reiterate all these previously mentioned mechanisms. So I think these are challenging cases, as Dr. McParr mentioned, and it's often a very mixed picture. So in summary, we have a 44-year-old woman, history of alopecia, active methamphetamine smoking, who presents with several months of on and off eye pain and 2 weeks of worsening severe eye pain and decreased vision. Initial exam was notable for a sterile appearing, non-inflamed, perforated marginal ulcer of the right cornea and 3 contact lenses on the left cornea with underlying multifocal stromal infiltrates and large epi-defect with patchy thinning. An extensive rheumatologic and systemic workup was effectively normal. Patient underwent a patch graft in the right eye, treatment of corneal thinning with a patch graft in the right eye, and treatment of corneal thinning with superimposed potentially bacterial keratitis associated with the contact lens use in the left eye, along with high-dose systemic steroids out of concern for possible PUK as well. The patient was lost to follow-up after post-op month 1, though her cornea has re-epithelialized, no evidence of recurrence of melt in the right eye or progression of thinning in the left. I think this is a... Dr. Polito, excuse me.
And going back to the lashes, does methamphetamine cause lash?
I would say, not that I know that it causes lash loss, but chronic eye rubbing can probably be an explanation for that. Irritation from the smoke, perhaps, when you're smoking it and rubbing the eye. So I would say it's got to be related to it somehow.
Well, was Carol right about the...
Yeah, so methamphetamine is known... is known to cause like hypersensitivity and compulsive behaviors.
Right.
And I think methamphetamine use could kind of predispose to trichotillomania, particularly if these patients are smoking, have some irritation in the eyes, like Dr. McPara mentioned, chronic eye rubbing, and then along with that, if the lashes are irritated, could actually lead them to be plucking their own lashes while they're kind of influenced by the methamphetamine. And the other question here that I don't think we'll ever get an answer to is, if we think this is a toxic direct effect of the smoke on the right eye that led to the corneal melt, were these contacts in some way protective for the left eye that had significantly less thinning? Certainly caused their own host of other issues, but interesting to think about.
Yeah, it's an interesting idea, yeah, possibly.
Yeah, really, really challenging case, really well managed. These are really tough to approach socially, so making sure that we keep up on that is really tough in these cases. What I was going to ask, surgically, was the sclera involved, or was it mostly just the cornea? Were you able to just kind of patch it with regular tissue?
That sclera looked okay, so it was fortunately just cornea.
Yeah, because that can be challenging here too.
Well, thank you all so much for joining.
Good morning, everyone. My name is Dilru Amarasekera, and I'm one of the third-year residents, and I will be presenting the second case today. I have no financial relationships to disclose. So this was a 65-year-old female who initially presented to the Wills ER with eye pain and blurry vision. She had first presented to an outside hospital complaining of 2 days of headache, blurry vision, and right eye pain, and she was seen at an outside ER with an IOP in the 60s. She was given rounds of drops and oral Diamox and then referred to the Wills ER for further eval. She denied any history of similar episodes in the past. Her medical history was relatively unremarkable. She had no medical conditions, no new medications, and she denied any personal or family history of glaucoma. So on her presentation to the Wills ER, her vision was 20/800 in the affected right eye and 20/60 in the left eye. And her IOP was 30 and 18. Interestingly, she had a trace APD in the contralateral eye, the left eye. So this is a slit lamp photo from her initial presentation. Dr. Lee, do you mind talking to us about what you see here?
Sure. It's a slit lamp photo of what looks like the left eye here. Cornea is fairly edematous here. You see some decimate folds. Significant
right
arches. Is that the right eye? Yeah. I think you're right. Yeah, that is the right eye. So there is corneal edema, decimate folds. The iris looks dilated. Infratemporally, it appears like there's a pigmented sort of patch. It's hard to see exactly what that is, but it's likely posterior synechii, and about a 2+ NS cataract.
Thank you. And here's a little bit more of a magnified view. Is there any additional information that this picture gives you?
So yeah, that does confirm that that pigmented patch is iris adherent to the lens. The lens is showing what appears to be sort of an anterior sort of opacity, almost looks fibrotic to me. And yeah, that's it.
And this is another view with partial retroillumination highlighting the corneal edema. And again, that membrane that Dr. Lee mentioned on the lens. Dr. Pro, do you mind describing the findings in the left eye?
Sure. Basically, the conch looks normal. The cornea looks clear in relationship, obviously, to the other. So this is a nice clear cornea, but obviously a very shallow AC. Although no areas that I can see of iris to corneal contact. Again, another cataract, at least a good 2 or even 3+ NS. Looks like pretty much nucleus sclerosis.
Great, thank you. So as Dr. Lee and Dr. Pro mentioned, the significant findings on exam were significant corneal edema of the right eye with stromal and microcystic edema and near 360 peripheral iris corneal touch. The AC was grade 1 shallow, the iris was mid-dilated, and there was this very atypical appearing pigmented membrane across the pupil. Both eyes had significant NS, and the left eye had a narrow AC as well. Briefly, I wanted to review for the residents grading flat anterior chambers. There are 3 stages. Grade 1 is when there's just peripheral iris corneal touch, as compared to grade 2, where there's both peripheral and central iris corneal touch, but no touch between the lens and the cornea. Grade 3, which is more of an emergency in terms of management, has both iris corneal and lens touch, as you can see in the diagram. And this is a fundus photo of the left eye with a focus on the optic nerve. Dr. Myers, do you mind discussing the findings here?
Happy to. So the peripheral retina looks pretty good. The macula looks pretty good, but along the arcades there are some areas of reduced pigment. The vessels look pretty good, maybe a slightly reduced caliber of the arterioles, especially inferiorly. The nerve of average or slightly small size, perhaps, has extensive cupping with loss, especially the superior and inferior rim. And to me, it looks at least as cupped as pale, so it looks like a chronic glaucomatous optic neuropathy, probably, although there are other things. It could be that way.
Thank you. And we were unable to do a dilated exam of the right eye because there was such a poor view from the cornea. So as Dr. Myers mentioned, there was significant cupping of the optic nerve, and in clinic it was described as a 0.8 cup to disc. In the ER, a B scan was obtained of the right eye that showed a flat retina, no clear masses, and gonioscopy was attempted. The right eye, we were unable to visualize any structures given the corneal edema, but the left eye confirmed that the AC was shallow with an angle of A5B. The patient was also seen in clinic and biometry was obtained, and interestingly, both eyes had pretty similar axial lengths, around 22.5, and lens thicknesses were pretty similar as well, also around 5.5, but the anterior chamber depth was significantly shallower in the right eye at 1.8 compared to 2.2 in the left eye. Dr. Reza, what is your interpretation of these findings?
So basically, this is a patient with angular closure glaucoma when we have shallower anterior chamber in one eye compared to the other eye. We need to think about any source of zonulopathy in this case because the axial length is almost similar in both eyes. Or more anteriorly located lens. These are the 2 main concerns, but in most cases, we have zonular issue when we have shallower anterior chamber in one eye.
And just a comment, though, of course, there is some corneal edema here, and do we have a measurement of the corneal thickness? It could be also a little relative AC shallowing.
We unfortunately do not.
But I agree with Dr. Reza, and there could also be like a synechial process sort of zipping up that angle, obviously.
So we also obtained OCT and visual field testing. Dr. Pro, do you mind talking us through the OCT images?
Yeah, I mean, it's difficult from here to see sort of the quality, but you always want to take a quick glance at the quality and of the image. But presumably it's okay on the left eye. Obviously, no imaging, not unexpected there in that right eye. But grossly thin RNFL, as Dr. Myers says, it could be many processes, but certainly could be glaucoma, and looks kind of consistent with sort of thinning, both inferotemporally and superotemporally. And on that fundus photo, it did look like there was a little more, I thought, inferotemporal thinning. But again, hard for me to see that quadrant out very much. But once more, it looks consistent with glaucoma as long as some other things.
And any further comments here?
It looks pretty normal.
And this is the octopus visual field. Do you mind talking us through this as well?
Yeah, octopus visual field. I mean, similar to Humphrey, and you can kind of look at it in sort of the grayscale kind of thing as the give you sort of an overall gestalt. Obviously, this is a severely constricted visual field based on that grayscale, and pattern deviation sort of shows the same thing. Once more, a sort of broad differential, but given the way the nerve looks consistent with glaucoma, advanced glaucoma, if that's true. Obviously, you need to do many fields to see if that's truly the case, but that's my impression.
Perfect. So at this point, we've kind of seen that this patient has bilateral shallow chambers and elevated intraocular pressures with signs of severe glaucoma in the left eye, but also has the presence of this very atypical appearing membrane on the right eye. Dr. Reza, what is your differential for things that could be going on here?
So this membrane is unusual for having a pupillary membrane because if it's congenital, the pattern is different, and also the patient may notice declined vision since childhood. Could be malignancy, so we need to look for that process. Could be because of repeated subacute angle closure glaucoma attack, some sort of PAS formation, iris pigment epithelial proliferation. We may also consider eye syndrome. That's one of the other differential in this list. And also could be because of any uveitis chronically that may have caused some changes in the iris pigment epithelium. But I think with this situation, we need to consider any malignant process before doing anything surgically.
Thank you. And Dr. Shields, do you have any additional input on what your thoughts are regarding this membrane?
Yes. It sort of has like a geographic look to the margin, which would be unlike a tumor. And this linear strand would be unlike a tumor. Most tumors are kind of round or ellipsoid and have fairly smooth margins. One thing this could be, as I look down here, it almost looks like there's a component that goes behind the iris. And I'm just wondering if it could have been an IPE cyst that may have ruptured, like a very large pigment epithelial cyst. So intersegment OCT or ultrasound biomicroscopy may be helpful in a case like this.
Great, thank you. So as we discussed, something that we do have to rule out prior to further intervention is any type of malignancy that this membrane could represent, such as an iris melanoma. Other differential are benign entities like iris melanocytoma or iris nevus. And as we discussed, this could be a congenital pupillary membrane, though it would be atypical as it was a very large membrane. The patient denies any prior ocular history or amblyopia. Other differential includes pigment deposition or variant of ICE, as Dr. Reza mentioned.
Can you go back to the previous, just for the teaching of the resident, the type of the cataract that we can see here, this is glaucoma flecken, which happens after acute pressurized in patient with acute angle closure glaucoma. Thank you.
Thank you. So Dr. Pro, what would be your next steps in diagnosis and management of this patient?
I think I would ask Dr. Shields. I mean, how, because obviously if we go into this eye, if we're saying, you know, the cataract needs to come out, and this looks like a case in which the cataract needs to come out, plus or minus some kind of glaucoma procedure is what I'm thinking, maybe a trab or two. But I mean, if you're going to do that, you would like to know beforehand, what you're getting into and what kind of approach to take to either get a sample or not. So I'd like to know what her thoughts are.
Great. And is there a role for an LPI at this point in the right eye as a temporizing measure?
No, I mean, if you have an elevated pressure and presumably a lot of synovial closures is what I would presume, I would not be zapping away with a laser. You could do it in the left eye, but not the right eye.
Perfect, thank you. So the patient did receive an LPI in the left eye only, given the narrow angle. And a UBM was performed of the right eye, and the patient was referred to ocular oncology. Dr. Shields, do you mind talking us through these UBM images?
Sure. So we can see the cornea, the iris, the lens. I presume this is that posterior synechii that we were noticing. It looks flat, it doesn't look thickened, it doesn't look cystic, and then it's attached to the other leaf of the iris. And I don't see any clear-cut tumor or cyst on this picture. To me, it looks like angle closure with some type of maybe inflammatory membrane. I can't even say inflammatory, I would just say with a membrane on the anterior surface of the lens. And then the measurement of the lens thickness was 5.5 millimeters. And we can see the angle closure here. So this would be like a grade 1, right?
Yes.
Because it's just the peripheral iris.
And then this is the left eye.
So normally when you measure the anterior chamber depth, you measure it from the endothelium to the front of the lens. So someone here measured it from the epithelium. So it's going to probably be less than 2 millimeters.
Interesting.
So this is the left eye, and the left eye shows, again, shallow anterior chamber angle. The leaves of the iris resting on the lens, and the lens is 5.45 millimeters in thickness.
Great. Thank you so much, Dr. Shields. So the patient was evaluated by oncology, and the UBM showed a shallow anterior chamber 360 with no evidence of iris or ciliary body masses, and the patient was cleared for surgical intervention. So Dr. Lee, what would be your operative plan for this patient and management of their elevated IOP and this membrane?
So as those UVMs showed, like the striking feature in this patient's eye is the thickness of the lens and that anterior vault we saw on it. The axial lengths weren't crazy short, so it's really the lens. So in this patient, I think primary thing to do is remove the lens. Of course, we have to contend with that synechia eye there. Oftentimes these things just sort of peel off. So first, create some side port incisions and viscoelastic. Then you're going to peel that off, perhaps with Utrata. Then you do your cataract surgery as planned. If there was no great view to the back of the eye after I removed the lens, then I may take a look at the fundus, look at the optic nerve, see what the status is, and then consider doing, that'll help me choose my next steps. If there isn't a lot of nerve damage, then I may just do a goniosynechial lysis and a goniotomy. If there is a lot of nerve damage, then I would perhaps do some sort of filtering procedure. My guess here is that there isn't as much nerve damage in this eye, fortunately, as the APD was in the other eye, but that's how I would approach it.
Thank you.
And that's not the posterior leaflet of the iris that's stuck down on the lens, is it?
I mean, it looks like iris pigment epithelium stuck in the lens.
And if you were to place a tube shunt in this patient, how would you decide whether to place it anterior sulcus or pars plana?
Pars plana, I like putting tubes. The further back you can put it, the better. But with pars plana, it just makes it much more complicated. You got to get retina involved. So, unless there was no space in the AC, then my preference would be to put it in the sulcus.
So for glaucoma, are we thinking this is angle closure related to angle closure alone or angle closure plus thick lens, crystalline lens?
I think it's the latter, angle closure plus thick lens. Yep. I still can't explain that sheet of pigment though. Sometimes you see that in post sort of LPI patients where they had some inflammation focally in that area, and then they dilate, and then you see a little bit of pigment on it. But
have you seen a membrane this dense before?
I haven't.
Would be just help answer that question. Would be nice to know what happened to the angle in the other eye. I mean, we're getting a little academic, but what happened to the angle in the other eye after the LPI? If you did have, a nice response, I mean, then obviously there is an element of pupillary block, and maybe, but clearly the lens is also involved, and it's hard to always really tease those things out. As we've seen from, for instance, the EAGLE study, taking out the lens is often important in angle closure. So those two things are always and forever interrelated.
So basically no change in angle configuration in the left eye. With this shallow anterior chamber, which is less than 2 millimeters, and a thick lens that you have, when you press against the cornea, you don't have any change because the lens is holding, and the iris, you don't have any room for the iris to fall back to be able to do indentation gonioscopy. So it was almost the same, no change in the left eye, yes.
And I think the UVM also didn't show much of any fluid pocket behind the iris in front of the lens. So that also would support this being a lens process and less a pupillary block, although they can coexist, of course.
Thank you. So this is the surgical video from Dr. Reza. Dr. Reza, do you mind talking us through your steps that you took here?
So the chamber was really shallow, and after injecting the dye, this is the viscoelastic agent cannula going under the membrane to release the membrane. The same thing, the cannula. So the membrane was attached to the border of the pupillary iris. And then here, capsule rhexis through the side port. When you have a really shallow anterior chamber, it's safer, it's easier to complete the capsule rhexis with the cystotome through the paracentesis, because when you use the utrato, it's not easy because you get this really shallow anterior chamber. And here, the membrane is removed for the pathology and then doing the phacoemulsification. The view was not that great because of the corneal edema and swelling. When you have a shallow anterior chamber, when you're removing the cataract, the bulk of the lens is keeping your posterior capsule back. But as soon as you have removed the major portion of the lens, the posterior capsule will start coming forward. That was the problem that we had. And one of the things that has been discussed and hypothesized in angular closure glaucoma patient is choroidal expansion. So you have an eye with really high intraocular pressure. As soon as you enter the eye, you decrease the pressure, you increase the chance for choroidal expansion. So here I had a really hard time for removing that small piece of the nucleus because the posterior capsule was almost against the anterior capsule. And here I'm removing the epithelium to get a better view. We can appreciate the difference between two sections in the part that I have removed the lens, removed the epithelium and the peripheral part. Because of having a really shallow anterior chamber, I did the vitrectomy. I requested 25 vitrectomy probe. They gave me 25 trocar and 23 vitrectomy probe. So I had to do the second trocar. And then it was much, much easier to remove the lens material. Then after removing the cortex, the CTR was placed in the eye and also the lens. So we discussed some problem for the zonules, and also when you do the surgery in an inflamed eye, after the surgery, you will have a lot of inflammation that may promote the capsular fibrosis, CCC, capsule contraction syndrome. So it's better to put a CTR. And also when you have a lens with thickness of more than 5, when you put the lens in the eye, you may get some sort of radiation alongside the haptic. So it's better to put a CTR to redistribute the force and have less posterior capsule fold. And then we did the tube shunt surgery, and the tube was placed in the sulcus because when you have a peripheral anterior synechiae, when you're entering into the anterior chamber, there's a chance that you may damage the root of the iris, you may get hyphema, you may cause iridodialysis, you may cause cyclodialysis cleft. And after the surgery, with this inflamed iris, dilated iris, if you put the tube in the anterior chamber, it may wrap around the tube. So it's safer to put it in the sulcus in these cases.
Thank you so much, Dr. Reza. So during the surgery, Dr. Reza performed a limited pars plana anterior vitrectomy to deepen the anterior chamber. And in a review of the literature, this technique has been described a few times as something that can be especially useful in phacomorphic glaucoma to facilitate lens removal. A shallow anterior chamber during phaco predisposes the patient to complications such as peripheral rhexis tears, iris prolapse, capsular rupture, and suprachoroidal hemorrhage. So performing a limited pars plana vitrectomy using either a 23 or 25 gauge trocar can help deepen the AC and allow the iris lens diaphragm to move posteriorly. And it can be done multiple times throughout the surgery. So also during the surgery, we were able to send a piece of the iris membrane for pathology evaluation. Dr. Eagle, do you mind talking us through the images here?
Yeah, just a sheet of intensely pigmented cells consistent with iris pigment epithelium.
Great, thank you so much. And as we discussed, our hypothesis for why this could have existed on the lens was because of repeated episodes of angle closure and iris pigment deposition. So post-op day 1, the patient had improvement of vision in IOP to 15. The sulcus tube was in good position, as was the lens. And we now had a view to the back that showed some cupping, but a grossly flat retina. On post-op week 1, the patient had developed some new choroidals abutting the macula. Vision continued to improve, however, to 2150 and an IOP of 11. And the patient was managed conservatively with atropine and prednisolone.
How do you monitor the sulcus tube? How do you monitor it to see the tube in the sulcus?
After the surgery,
Yeah,
we see the tube.
so you can visualize it.
We see the tube because the pupil is so dilated. We usually put the tube a bit longer than usual.
Okay.
We can see the tube.
Okay, so you can
In
see
this
it
case,
behind the iris.
Right, it is behind.
And if you had already a pars plana incision, why not use that pars plana incision for the tube?
Because we need to do a complete vitrectomy as soon as the shunt start working. Any vitreous that you may have will eventually clog the tube. We just did a dry vitrectomy to deepen the anterior chamber. It was not a just tiny amount of vitrectomy.
And just briefly, Carol, when you do the sulcus tube, and he showed a great example of that, you want to make it beveled down, so you try to avoid any iris tissue getting into the tube.
So it's sitting on the front of the lens.
So more beveled down towards the front lens, and ideally you want to sort of see just the tip of the tube at the edge of the iris. And sometimes, in this case, the iris is basically going to probably remain pretty dilated. But in some cases, obviously, you have a normal-looking iris, and in those cases, sometimes it can be difficult because you think you're in the right place, and then afterwards you don't quite see the tip as well as you would like. But ideally, you just see the tip of the tube, so you feel a little better post-operatively that your tube is not going to be obstructed.
Thank you. So by post-op month 1, the patient's vision continued to improve 2150 with an IOP of 17, and the choroidals had resolved. And this is a post-op month 1 slit lamp photo showing the deepened anterior chamber and the IOL in good position. And this was a fundus photo of the right eye optic nerve showing cupping, but again, not as severe as the left eye. And this is a UBM of the right eye at post-op month 1, demonstrating the tube in the sulcus right here. And this is another interesting UBM photo that shows how high the PAS in this patient were. So in summary, this was a patient who presented with acute unlikely chronic angle closure glaucoma with a phacomorphic component, and this very atypical appearing iris membrane preoperatively underwent an oncology evaluation, and it was found to be later consistent in pathology with iris pigment epithelium, likely due to repeated episodes of angle closure in the eye. Patient underwent complex cataract extraction and sulcus tube shunt placement with anterior vitrectomy used intraoperatively to deepen the AC. And she had improvement in her vision and pressure postoperatively. These are my references, and thank you to Dr. Reza, Dr. Shields, Dr. Eagle, and Dr. Yang.